I think all of you will agree with me. So now we are starting with this discussion on Six Sigma. I think all of you will agree with me. These days, laboratory medicine has assumed a central place in any healthcare organization. What exactly we are doing? We are generating important information for the better patient care, either in the form of number or some descriptive information, which is then utilized by clinician for better patient outcome. What is their expectation? A correct report, accuracy of the report, and that report shall be available within reasonable time frame. And whatever we are doing in our laboratory, we want to fulfill these two requirements. For this, we are following ISO 15189 in our laboratory. We are getting our laboratory accredited. But what is happening? One thing is we want to improve activities within our laboratory. But how to quantify that? And how to quantify in an objective manner? That knowledge is lacking. And when we apply Six Sigma in our laboratory in the various activities, we can quantify our quality and we can discuss with our stakeholders in a more effective manner. So now, how we can quantify this? This we will discuss. And why it is important? Because 70% clinical decisions are based on our reports. And what is our intention? We want to release error-free report, which is meaningful for clinician so that they can make a correct diagnosis. They can provide correct treatment to the patient. And ultimately, as a laboratory person, we are contributing in the better patient care. For this, what we do, we tell our users, we are working with the quality. We are assuring them about the quality. Now they may ask, what is the basis of this quality assurance? You are telling us you are maintaining quality. See, not only examination part, we are taking good care of pre-examination and post-examination also, because 85% errors, or you can say more than 85% errors are occurring during these phases, pre-examination and post-examination. And generally, when we talk about our laboratory, what we say, we have very good equipment. This equipment is present only in our laboratory all across the country or all across the globe. But if these pre-examination, post-examination processes are not well controlled and we bring in automation, what all we get is automated mess, nothing else. We are taking good care of quality control. And how? We have well-defined, well-documented quality management system. And when we get our laboratory accredited, what is the meaning of that? We are following international standard ISO 15189, which is designed for medical laboratory only. We are defining our procedures to see how we are carrying out a particular activity, stepwise manner. That we are maintaining records, evidence of implementation of various activities. You may be wondering why, instead of telling you about the Six Sigma, why I'm telling all these things? Because we will apply Six Sigma in these areas. See, what is happening in our laboratory? Patient is coming with test request form in his or her hand, and they are going with the report. And in between, we are carrying out various activities, like we are collecting their samples. Sometimes they may like to ask that 2-3 different type of tests are available. What is the best suitable in this situation? Or some clinician may ask something, so we are advising them. We are collecting samples, following proper guidelines. And if suppose we are sending a particular sample to referral laboratory, we are informing patient about that. Then we are carrying out tests by appropriate method. And taking good care of our internal quality control and external quality control. When we are releasing result only to authorized recipient. We are adding every information which is required for the interpretation of a particular test. But to carry out all these things in an effective manner, what is required? If suppose somebody is not happy with the laboratory services, we are taking good care of those complaints and we are informing complainant also about the action taken. And if we are detecting any non-conformance means which is not as per our documented quality management system, we are taking good care of corrective action or preventive action, whatever is required. And regularly we look for continual improvement, how we can further improve our laboratory services. For this, we evaluate various activities. Time to time, we conduct audit also, and we are participating in AQUAS and IQC. Now, for all these things, we are discussing so many things. What is required? We have to define our organization. Somebody is heading the department. Management is also actively involved in the laboratory activities. They are supervising laboratory activities because, as we discussed, 70% clinical decisions are based on our report. Then we are taking good care about the requirement of service agreement, how we are providing services to our users. Management is also time to time discussing with the laboratory people how they are carrying out various activities, and we are defining our quality management system. We are taking good care of documents used in the laboratory, whether these are internally generated document or externally procured documents. And what is record? Record is evidence of implementation of activity. So we are maintaining all records for a defined period. And for all these things, what is required? People working in our laboratory, they are qualified and trained to carry out various activities. We are taking good care of our accommodation, environmental condition. Laboratory temperature is well maintained, cleanliness is well maintained, our all equipments, reagent and consumables. These, we are following all appropriate guidelines related to these, and we are selecting our vendor appropriately and also taking good care of laboratory information system. Now see, if you visualize our laboratory, I think every laboratory, they are receiving requests, then they are collecting samples, then they are transporting samples, then samples are received in the laboratory. Then they prepare aliquots and send these aliquots in the different sections. There they register these samples in their respective laboratory through their laboratory information system and perform tests by appropriate method. And then these results are interpreted and results are released. If there is some critical result which require immediate therapeutic intervention, these are informed to clinician immediately. Now, this is the flow chart being followed in each and every laboratory. Then what is the difference? When we say one laboratory is a good laboratory, another laboratory is not so good laboratory, where is the difference? See, in a good laboratory, they have defined procedures at each and every step. Then there is uniformity in the system. Chances of errors are less. The laboratory has to define procedure according to their requirement, whether at the time of registration or at the time of performing test or releasing result, because different laboratories, they have different requirements. Some laboratories standalone laboratories, some laboratories are hospital-based laboratories, some laboratories they have few other associated laboratories, some laboratories they have collection centers. As per your requirement, you develop a documented system for the better functioning of your laboratory. Now, we have to develop a powerful tool. If we have two equipments, how we can compare results between these equipments? If we have 4 or 5 options, suppose you want to buy a new hematology analyzer or biochemistry analyzer or hormones analyzer, how to compare these different equipments and how to optimize QC procedures. One thing is you are saying, oh, we are NABL accredited. So we are following 112. What is written in 112? But we have to think beyond this ISO 15189. We have to think beyond this 112. How many controls we have to run in our laboratory, how frequently these shall be assayed, and what all Westgard rules shall be applied in our laboratory. We have to understand these also, which is based on data generated in our laboratory. And with this, when we apply Six Sigma, either we are checking process variation or we are assessing process outcome. And ultimately, what is our intention? We are working towards the improvement in our laboratory performance. But generally, what happens when we try to evaluate? Everyone will evaluate in his or her own manner. So there is a lot of subjectivity. I think all of you can identify this gentleman. When we talk about sigma matrix, what is sigma? Sigma is a symbol used for standard deviation. 1 sigma, 2 sigma, 3 sigma. And when we apply the 6 sigma, what happens? Whatever activity we are using, we count number of errors observed in that activity in a particular time period. We count those errors. Then we convert these to defect per million opportunity. Suppose we want to see unlabeled samples received in laboratory. Suppose there are 10 unlabeled samples in 1,000 collected samples. So these are 10 errors. This is the term which we use in this sigma matrix. When we convert this into million, 1,000 is converted into million. How? 1,000 is multiplied again by 1,000. And now you are multiplying 10 by 1,000, it will become 10,000. 10 per 1,000 collected samples means 10,000 per million. Then you can get this table from the Google. This defect per million opportunity is converted into sigma matrix. Closer it is to 6, better is the performance of your laboratory. When we say some activity is performing with quality of 1 sigma, that means there is possibility of 6,91,462 defects out of 1 million opportunity. 2 means 3,08,538. 3 means 66,807. 4 means 6210. 5 means 233. And 6 means 3.4. What you have to realize, sometimes we say in our laboratory, our correctness is, please don't write anything on the screen. This is very disturbing and it will disturb all of you. So please don't write anything on the screen. If you're not able to understand anything, so you can write in the chat box. But drawing a red line or green line, this is not a good practice. Suppose you are saying in our laboratory, correctness in a particular activity is 99%. With this 99%, you are very happy. You are correct 99 times out of 100 opportunity, 100 possibilities. That means 1 error out of 100. And what is the meaning of this? 1 error out of 100 means 10 errors out of 1,000 and 10,000 errors out of 1 million opportunity. So this you have to realize. So closer it is to 6, better is the situation. And sometimes you may find 6 sigma higher than 6 also. Now we have to understand certain terms. Sometimes we use this term bias. Sometimes we use this term imprecision. Bias is lab result minus group mean divided by group mean. And if you multiply this by 100, you will get bias percentage. Imprecision means standard deviation divided by lab mean into 100. This bias you are calculating from your equals. Bias percentage you are getting from your equals, and imprecision you are getting from your IQC. And this is very important. All of you please concentrate. This is very important to understand. Sometimes we say in our laboratory, our equals performance is very good. In our laboratory, our IQC performance is very good. But suppose some clinician is asking, I'm endocrinologist, started practice in your area. I want to send my hormones to your laboratory. What is the reliability of your TSH or prolactin? If you're telling them in terms of equals and IQC, they will not understand. They want to know the correctness of the result. If you're telling them in terms of 6 sigma, and how, that we will discuss. Now we can calculate this bias percentage. Bias means how much variation is there from the target value in your result. And imprecision means when you are running a sample daily or maybe more than one time daily over a period of time, how much variation you are observing over a period of time. Both are important. So now, what is the utility of this? We calculate 6 sigma based on this bias percentage and CV percent, and then we utilize that in assessing the process variation. How much variation we are observing in our glucose estimation, how much variation we are observing in our TSH estimation. And when we apply 6 sigma in a particular activity, number of unlabeled samples received in the laboratory, number of hemolyzed samples received in the laboratory, number of times clot observed in the sample in our laboratory, that is outcome of a process. If you are saying error in typing, in report, in post-examination, that is process outcome. How many times it is happening in a month, then you can convert this, or in a year, then you can convert this into 6 sigma. Or a report released to unauthorized recipient. By mistake, Madhu Kabra report released to Madhu Kamra. This is process outcome. So we have to see there are two things. One is process outcome, another is process variation. In both these scenarios, we can apply this 6 sigma, and over a period of time, we can analyze whether we are improving in our activity in these areas or not. For process outcome, number of defects, then these are converted into defect per million opportunity, and through table you can get from the Google, it is converted into sigma matrix. And if suppose the sigma matrix is increasing over a period of time, so that means our quality is improving in that activity. And this we can apply to pre-examination, this we can apply to our examination, and this we can apply to our post-examination also. For process variation, how we can calculate 6 sigma? Total error allowable. This we get from the literature. Either CLIA guidelines, or there is some guidelines by CRECOS. You can get on the Westgard website also. And there is one guideline by Relay Bank. So these are the different sources of getting this data of total error allowable. This you are not calculating in your laboratory. This you are getting from the literature. From this you are subtracting bias, which we are calculating from our equals, and we are dividing this difference by CV%, which you are getting from your IQC. Now, if suppose 6 sigma is low, what are the possibilities? Either TEA, total error allowable, is a constant. We are getting from the literature. Either the bias is high, then this difference is less, or the CV is high. This is a denominator. So if this is high, you will get low value when you are calculating. So low 6 sigma means either high bias, which is decreasing the difference, or high CV, which is decreasing this fraction. So now, how to analyze? If suppose 6 sigma is low, below the acceptable limit, how to analyze this low 6 sigma? What is the reason? And another thing is, all of you, please fill the attendance form, because this program is accredited by State Medical Council. We are running this program from Delhi, so this is accredited by Delhi Medical Council. All of you will get the certificate accredited by Delhi Medical Council, but for that it is a mandatory requirement. We have to submit this record to State Medical Council, that is our Delhi Medical Council. So please fill the attendance form. And we will also post feedback form. Please fill that also, because regularly we are conducting these programs, I think almost 3 or 4 times in a month, and all these programs, these are accredited programs, so we have to fulfill certain mandatory requirements of State Medical Council. So this program will be over by 7 o'clock. So before that, you fill this registration form, because after that, even if you have attended the program, you will not get the certificate, because this list is approved by the State Medical Council, and then these certificates are issued. Now, when we calculate 6 sigma for our process variation, minimum acceptable performance is 3 sigma, and world-class performance is 6 sigma. And how to analyze this low 6 sigma? We calculate another term, quality goal index. And this bias is divided by 1.5 into CV. It is applicable only to those cases where the 6 sigma is below the acceptable limit, not in all cases. Now, if suppose this quality goal index is more than 1.2, that means bias is high, and bias suggests inaccuracy. So there is inaccuracy. If suppose quality goal index is less than 0.8, so that means CV is high, there is imprecision. And if this quality goal index is between 0.8 to 1.2, that means there is inaccuracy as well as imprecision. So this we have to understand. See, in this, on x-axis we are plotting imprecision, and on y-axis we are plotting inaccuracy. It should be as close to 0 as possible. Closer it is to 0, better is the situation. And you can see if this imprecision is less, so you can achieve world-class performance. So you must have seen this type of graph in some books also. So it should be as close to 0 as possible. We performed one study in 2019. Now I'm explaining you how we can apply this in process outcome and in process variation. Hope my voice is clear to all of you. Okay. We analyze these 10 analytes from March to August 2019. We calculated CV% every month for 6 months for these 10 analytes, and then we calculated the average. Similarly, we calculated bias percentage based on Equus performance for the same 10 parameters, same period, March to August. And then we analyze this data. We took this total error allowable from Westgard website, then average bias percentage and average CV percentage. And with the formula total error allowable minus bias percentage divided by CV percentage, we calculated sigma matrix. And in the fourth column, this is the sigma score observed in these 10 parameters. Now you can see for this creatinine, glucose, potassium, and total protein, this sigma score is less than 3. And what we discussed, less than 3 is not acceptable to us. Or you can say above 6 sigma was observed for this SGOT and magnesium. 5.9 to 3.0 was observed for albumin, SGPT, calcium and urea, and less than 3 was observed for creatinine, glucose, potassium and total protein. And we said less than 3 is not acceptable to us. We will analyze these. So when we analyzed, we found for these quality goal index for creatinine was 0.6. 0.6 means it is less than 0.8, and less than 0.8 means CV is high, imprecision. For glucose, it is between 0.8 to 1.2. There is imprecision as well as inaccuracy. For potassium, it is 1.2. 1.2 means bias is high, there is more inaccuracy. Some element of imprecision may be there, but predominantly it is inaccuracy. And total protein 1.0, there is imprecision as well as inaccuracy. So that way you get the clue how to proceed further, how this data shall be analyzed further. And we can use this Six Sigma for designing our quality control also. How many controls shall be run, how frequently. But first you develop understanding how we can use this for process variation. As we discussed, we will discuss all these things in a separate lecture in detail. I am only telling you that this can be used. So first you start using this for process outcome and process variation. Process variation we just discussed with the example of one study, and how then you can utilize this we will discuss little later. Now suppose you're getting variation in your result. What is the possibility? There may be inaccuracy, there may be imprecision. If you are getting variation, there may be some change in the reagent or some change in the control, or some maintenance required was not performed. Some problem may be related to calibration. There may be change in the lot of calibrator, or after last maintenance or service, there is either some shift or some trend. Shift means there is change in the value and then the change is maintained. Trend means the results are moving in one direction, or you have changed the lamp. After lamp, the light has increased. It is causing some problem or some deterioration in the lamp. Reagent shelf for onboard stability. Date of reconstitution of the control, and after reconstitution, you are storing these controls after making aliquots. And now suppose these aliquots are not stored properly. Daily someone is taking out the box and running control and then keeping the box again in the refrigerator. The last 3-4 days you may find some variation, you may find some trend because of the control deterioration. So all these things can cause variation in your result. Or after reconstitution, after bringing that control to room temperature, it is not mixed properly or some bubble in the aliquot. These are for random error. You're finding error in a particular result, in one result. After that, if you're running control, you're not finding that error. Or temperature, humidity of environment and instrument, calibration status, some electric fluctuation, some lot change, any instrument error. So all these things can cause variation in your result. The important thing is when you are applying, you have to understand what are the areas where you can apply this Six Sigma. And if Six Sigma score is decreasing in a particular situation, then what are the possibilities in this? How to take appropriate action? So when we talk about process outcome, we just discussed our process variation. So we have to see what are the areas where we can apply this Six Sigma in the process outcome, in the pre-analytical phase, in the analytical phase, and in post-analytical phase. For this, we have to change our habits. When we are changing our habits, only then we can improve in that area. Otherwise, whatever has been happening since long, same thing will keep on happening for the rest of the period also. One thing is Six Sigma. With Six Sigma, we improve the quality. Another thing is lean concept. Whatever is not required, whatever waste is there, you're removing that. As people exercise a lot, they consume less calories just to remove extra fat from their body. Then they look lean. Similarly, if we follow certain practices, this waste will be removed and our laboratory activities will look more attractive. Increase in sigma matrix, it is a sign of high quality. There is increase in the productivity, increase acceptability by the consumer, and increase in the reputation of the laboratory. And also there will be decrease in the repeat of testing. There is less wastage of things which we are keeping in the inventory. Our turnaround time will decrease because we don't have to repeat test more frequently now. And our analytical time, or you can say throughput time, will be better. So just for this process outcome, for this also we performed one study during the same period, and we collected 16,562 samples. Out of these, 6 were hemolyzed. In 7 cases, there was venipuncture failure. In 9 samples, clot was observed. Total number of errors were 22. 6 plus 7, 13, and 9, 22. 22 means when we calculated the percentage defect was 0.132, and when this was converted to Six Sigma, we converted this into defect per million opportunity, and after that 6 sigma. These were the 6 sigma score in various areas: 4.5, 4.9, 4.8, 4.7. Then we analyzed what may be the reason of these failures. Either improper training, poor people, they were not mixing sample properly, or mixing very vigorously, or samples were not stored properly. So these were the reasons. For this, what is required? One thing is training, and after that, post-training evaluation is also very important, whether they have understood the concept or not. And we have to see they are mixing samples properly and they are storing samples properly. To develop action plan, we will provide regular training to our people, and we will also do competence evaluation. What is competence? Ability to use acquired knowledge and skill in practical situation. We will monitor our environment also, and we will reevaluate the sigma matrix after 6 months. And what is our aim? We want to achieve 6 sigma above 5 in all these areas of pre-analytical. When we use 6 sigma in various activities, what is required? We say this is DMAC principle: define, measure, analyze, improve, and control. What is required? First, you identify areas where you want to apply this 6 sigma. Certain activities related to process outcome, certain activities related to process variation, and what is the demand of your customer. Suppose your customers, doctors and patients, they are saying, we are getting reports very late, and suppose you have defined turnaround time in hospital setup, suppose as 4 hours. In how many occasions they are getting report after 4 hours? Number of instances where they are getting report after 4 hours divided by total number of possibilities. So you can calculate this, and you can convert this into defect per million opportunity and ultimately to 6 sigma. Or patient may say they have to wait very long, and you are thinking up to 30 minutes it is okay. But this waiting period shall not be more than 30 minutes. So you can identify these possibilities. So first you are defining. Then you are collecting data for this process variation and process outcome. You are collecting data. After collecting data, analyze that data. After collecting, you are converting into 6 sigma after calculating defect per million opportunity. And for process variation, you are calculating bias percentage and CV percentage, that is your inaccuracy and imprecision. And then you are converting it to 6 sigma. Now you have 6 sigma. And for this process variation, you are also calculating QGI, quality goal index. Now, whether there is imprecision, inaccuracy, or what is the sigma value of a particular situation, you are planning for improvement. How to improve in this activity, which will optimize your workflow. You have to look for improvement, and you have to implement that improvement plan. When you are implementing that improvement plan, you have to monitor very carefully, because what is required, it shall not go back to the original score. If suppose at present your 6 sigma score is 4.5 and you are looking for improvement, and suppose for 2 months it is 5.0, after that 5.2, and you are thinking now everything has been settled, and after 3 months you are realizing now it is again 4.5 or 4.6. So this shall not happen. Correct. Monitoring is very important, because when you are monitoring, whenever it is required, you are taking appropriate action. Ultimately, it will become habit of the laboratory in that particular activity. When we talk about waste, we were discussing lean concept, incorrect data entry. If data is incorrect and report is typed incorrectly, and when you are checking, you have to take extra printout, because some report, some defect may go undetected, ultimately loss of reputation for the laboratory. Overproduction, if suppose you have produced one report, you have checked, but when you are issuing report to the patient, that report is not available for some reason, then you are preparing extra report. This is waste. In transportation also, if you are not following proper guidelines, waiting time is high for billing, for sample collection, report dispatch, inventory is not managed properly, or some talent of a particular person is not utilized properly. So you are appointing separate person for separate activity. In conclusion, you can understand Six Sigma helps us in cost saving and resource management. And it also helps us in developing appropriate QC strategy in our laboratory. Now, another thing is, which I always find very confusing. I always find a lot of uncertainty regarding the understanding of measurement uncertainty. If you people are interested, I can explain you in 3-4 minutes, because this is something which I always find people consider as difficult. All of you don't have to worry, you will get attendance link after every 15-20 minutes. You don't have to worry. But whenever we share link, so please fill and submit. Do you want me to explain measurement uncertainty, or is it clear to you? Okay. Okay. See, measurement uncertainty of measured quantity value. So it is applicable where you are quantifying something. Although there are a lot of uncertainty in our histopathology, cytopathology, peripheral smear examination, bone marrow examination, or various other types of microscopy. But there we cannot apply this measurement uncertainty. It is applicable only to quantifiable tests. We will start with an example. Suppose neonatal bilirubin in a particular case is 22.4, and clinician has to take decision about exchange transfusion at 23. Now the clinician is asking you, sir or madam, are you sure? You are saying it is 22.4, and I have to decide exchange at 23. If I will go by your report, I will not perform the exchange transfusion. And if the actual bilirubin is more than 23, this bilirubin may cross blood-brain barrier, will be deposited in the basal ganglia, connectors, and ultimately severe mental retardation. Whole life of the child will be spoiled. So can I go by your report? Now you are a little confused. How to answer this query? You are saying possibility is it will not be beyond 23, but it is possible. Then it will not help them. Now, why we are generating result? We want to be active partner in the better patient care. If suppose you're telling them, see, all of you know the concept of statistics. I think as a medical people, we have read this in our PSM Park and Park. One standard deviation covers 68.3% data population. Two standard deviation covers 95.5% data population. And three standard deviation covers 99.7% data population. And two standard deviation is adequate coverage of any data. And for this, our biological reference interval also, we take central 95%. Two standard deviation is covering 95.5 and 95 is covered by 1.96 standard deviation. That is why you must have seen in NNBL 112 also, they have written 1.96. Otherwise, it is close to 2 only. So now if suppose you are telling clinician, see, for the last three, based on last 3 month data, our standard deviation for bilirubin at this level is 0.2 based on our control data. And 0.2 multiplied by 2 standard deviation would be 0.4. Whatever we are reporting as 22.4, we can say with 95% certainty, based on uncertainty observed in our laboratory, it cannot be beyond 22.8. Now they will also understand, oh, whatever they are saying, that has some meaning. Okay, we will wait for some time. Suppose after 4 hours, they are sending bilirubin again. Now your bilirubin is suppose 22.8 or 22.7 or 22.9, although it is less than 23. Now you can explain them the same concept, or they also know the same concept. Whatever they are saying as 22.8, it can be 23.2. And the bilirubin has already progressed in the last 4 hours from 22.4 to 22.8, even though the child was on phototherapy. So it is better if we are going for exchange transfusion. They will understand this is measurement uncertainty. It is not useful in every situation, but where it has utility, discuss with the clinician and provide them this information. Now, another thing is where examination include a measurement step, but do not report a measured quantity value. Laboratory should calculate the uncertainty of the measurement step where it has utility in assessing the reliability of examination procedure or has influence on the reported result. See, you are performing some calculation in your serology. If you are not performing by card method, you are using machines. So you are using this ELISA method. Then you are calculating absorbance. Suppose your cutoff value is 1. In a particular case, you are getting absorbance 0.6. You will report this as negative. Now you are running, suppose, positive control daily, and you are observing standard deviation of 0.1. If you multiply this by 0.2, it will be 0.2. If you will multiply this by 2, it will be 0.2. If you use this measurement uncertainty here, 0.6 plus 0.2, 0.8, it is definitely less than 1. You can report this as clear negative. But suppose absorbance is 0.9 in a particular patient, cutoff value 1, and your measurement uncertainty is 0.2. If you add this measurement uncertainty, whatever you are reporting as negative, it may be positive also. Similarly, a positive result may be negative. So you have to report with caution. Please get this repeated after 1 week or 10 days. because most of the serological tests generally get settled to this period. And clinician will also understand, yes, whatever they are saying, it has some meaning. Otherwise, what may happen, suppose you are reporting as negative, they are sending to some other laboratory, they are reporting as positive, and clinician is fighting with both the laboratory, patient is fighting with both the laboratory, and both laboratories, they are fighting with their company people. To avoid all this confusion, what is the solution? Understand this concept of measurement uncertainty and explain to clinician also. This will make your life peaceful as well as life of the clinician peaceful. Right? The final result which you are releasing from your laboratory, if you will follow these principles, you will get your peace of mind and confidence about the report, and you will get more data of satisfied customers. Thank you very much for this patience listening. Manisha is at present head of operations and head of quality in the very prestigious laboratory of Pune, A.G Diagnostics Pvt Ltd. Although she is born and brought up in Mumbai, she pursued her medical education at GS8 Medical College and KEM Hospital. And I think in KEM Hospital, almost every department is state-of-the-art department. They are doing wonderful work, and it is really worth to visit that hospital. We conducted one training program there, and this is really very good medical college and hospital. She received her MD Pathology in 1995 along with DPB. And for last 26 years, she is associated with this A.G Diagnostics. Previously, it was Wilker Laboratory. Now it is known as A.G Diagnostics Pvt Ltd. Her special interests are clinical biochemistry, immunoassay, autoimmunity, laboratory information management system, and process management in laboratory. She has played instrumental role and in the in-house development of laboratory information system for the organization. This has led to her expertise in integrating IT and lab workflow optimally. She has traveled abroad and hence is familiar with the current trends in lab automation and LIS needs. She has long experience in the field of quality and accreditation. And this Golwalkar lab was the first laboratory to get accreditation in the Pune. She is also technical assessor of NABL. She conducts ISO 15189 training programs very regularly. And she has pioneered the start of quality related teaching in Pune. And she is very comfortable in handling all aspects of laboratory management. She has in-depth knowledge related to various lab operations. And she is frequent and well appreciated speaker at various seminars, conferences, institutions at state and national level. So now I will request Dr. Manisha Patwardhan to enlighten all of us with her vast knowledge.
Is my screen visible?
Yes, Dr. Manisha.
Yeah. And am I audible, or you want me to? Okay. So can I start then?
Yes.
Thank you. So thank you, Dr. Neeraj Jain, for the wonderful introduction as well as the opportunity to interact with this large group today. Today we will be discussing a very, very common food item, and that is wheat. So we will be understanding wheat-related disorders and whether wheat is really a friend or foe to all of us. So I'll be taking you through the introduction to wheat, celiac disease, allergy, non-celiac gluten sensitivity, food intolerance, IBS, and then lastly, the approach to diagnosing these as laboratory professionals. So wheat is a grass which is cultivated for the seed. It's a worldwide staple food. It is grown on more land area than any other food crop today. It is an important source of carbohydrates and a leading source of vegetable protein, multiple nutrients, as well as dietary fiber. It has a long history. The earliest wheat was cultivated almost 10,000 years ago. And in the Indian subcontinent, it is being cultivated for over 7,000 years now. From the 19th century, it has become an item of mass consumption, thereby displacing other cereals like oats, barley, rye. And wheat breeding started in the 19th century, and modern wheat breeding is a continuous process. What I mean by breeding is that there is an ongoing effort by genetic modifications to bring out a crop which has a higher yield than earlier, good quality, and resistance to insects and diseases. So by 1997, 81% of the world wheat is the modified dwarf variety, and increasing gluten content to improve the quality of bread and pastas has also been an ongoing process. So what we keep hearing, and lay people also keep hearing about this, that there's a genetically modified wheat which is being used largely today. So it is true, and there is a continuous genetic modification being done in wheat and many other crops for that matter. But because wheat is so largely consumed, this has now assumed an importance. So wheat is practically ubiquitous every day in some form or the other, either as flour, semolina, malt, cracked wheat or bulgur wheat, daliyas and dharam wheats. We are eating it in various food products. So we have chapatis, puris, biscuits, breads, cakes, upmas, and pizzas, pastas, of course, today that they have almost taken over our Indian foods. And there is beer, vodka, there is breakfast cereals. So there are lots of ways in which we are consuming wheat every day. And there are many health claims made as to why wheat is good for us. So wheat is good for gut health, it is good for bowel function, digestion, weight control. It has got a good satiety index. The cardio, it can have a beneficial effect on cardiovascular health, blood glucose, insulin levels. And it has a good glycemic index, a favorable glycemic index. So all these are definitely the benefits of wheat, and that is the reason why wheat is being eaten in the quantities that it is being eaten. However, there is a concern now, which is because of the, just a minute, yeah. There is a concern now because of this increased consumption itself, because it is one, gluten is being taken in very large quantities because of this increased wheat consumption. And like I already mentioned, we are modifying the wheat. And so there could be properties of wheat and then the breakdown products of wheat, which can cause problems in humans. So let us understand the anatomy of the wheat grain. So a wheat grain, or any cereal grain for that matter, has a bran on the outside, an endosperm from where the flour comes out or the starch comes out, and the germ, which becomes a new plant if the grain is planted. So coming to the wheat proteins. So wheat flour will be divided into wheat starch and the wheat proteins. The wheat proteins have albumins and globulins and gluten. The gluten is again further divided into glutenins and gliadin components. In the gliadins, you have alpha, beta, gamma, and omega gliadins, of which please note that the alpha gliadin and the gamma gliadins are the standard targets for the test reactions, that is anti-gliadin antibodies and TTG antibodies. I will come to this a little later. So again, a chart which shows that the wheat proteins, you have a water-soluble part, which is gluten, and the water-insoluble part, which is gluten, and water-soluble part, which is albumin and globulin. In this water-soluble part, like I already said in the previous slide, there is gliadins and glutenins. So the gliadins are also known as prolamines. Do understand this term. They are prolamines. So what do these prolamines do? The prolamins disrupt the tight junctions between the enterocytes, which allow large amino acids to enter circulation and stimulate an immune response. And the prolamins are not found only in wheat, but they are there in barley, rye, oats, and corn. That is the other cereals which are eaten worldwide too. And wheat, of course, like I again said, is the most important. So the gliadin and the glutenin will have the maximum effect, if at all, on humans. Now, there is a very big spectrum of wheat-related disorders. The first group is where there's an autoimmune etiology, and the main of that is celiac disease. Then there is a group of allergy to wheat or gluten. It could be either a food allergy or a wheat-dependent exercise-induced anaphylaxis, as it's called, and a respiratory allergy or baker's asthma. So this is typically seen in bakers who are continuously working in large quantities of wheat flour, and they are inhaling a large amount of wheat flour particles. Then the third group is where an innate immunity comes into picture, and these disorders these are classified as non-celiac gluten sensitivity. Now, because there was a lot of confusion regarding the nomenclature, diagnosis, and treatment of these different entities, also a clinical overlap is seen between the entities, and there is a lot of self-diagnosis by patients also in most of these cases. So because of all this, an Oslo task force sat together and has tried to now define these entities better, and they have grouped it under the large umbrella term gluten-related disorders. So in gluten-related disorders, like I had already mentioned, you have the main one is celiac disease. A celiac disease could be symptomatic, or then there is a subset where the patients may have subclinical celiac disease. So milder symptoms, and however the serology and the genetic predisposition will be seen in these patients also. Then there's a wheat allergy group, and then there is a wheat sensitivity, which is the non-celiac gluten sensitivity group. There are also sometimes extra gastrointestinal manifestations of reaction to wheat, such as dermatitis herpetiformis and gluten ataxia. Again, like you see in this diagram, there's a huge amount of overlap between all these disease entities. So coming to celiac disease, the word celiac comes from the Greek word meaning suffering in the bowels. Celiac disease is an immune-mediated systemic disorder elicited by wheat gluten and related prolamins from rye and barley in genetically susceptible individuals. So it doesn't happen in everybody. We all are eating wheat, isn't it? It is not as if each one of us will have a problem. There is definitely a genetic susceptibility, and only when the phenotype is then superimposed on this genetic susceptibility. The other terms which were used for celiac disease were gluten-sensitive enteropathy, non-tropical sprue, or celiac sprue, which is now largely replaced by the term celiac disease. So like I said, the genetic susceptibility is in the form of HLA-DQ2 or DQ8 genes found to be present in more than 90% of the celiac patients. The receptors formed by these genes bind to the gliadin peptides more tightly in the form of antigen presenting cells. So HLA-DQ2 and HLA-DQ8, please remember these. So the pathogenesis is that there are three factors working together in disease causation. One is the environmental factors, that is eating gluten-containing foods. The immunological factors, that is this has led to presence of autoantibodies, anti-tissue transglutaminase antibody, anti-endomysial antibodies, and anti-gliadin antibodies. And like I said, the genetic factors, that is there's an association with HLA-DQ2 or HLA-DQ8 alleles. What is the pathogenesis of the disease? So there are multiple proposed pathways, and it is said that the gliadin plays the most significant role. It is directly there is a direct toxicity to enterocyte. It also causes an overexpression of interleukin-15 by enterocytes, which in turn triggers activation and proliferation of CD8 intraepithelial lymphocytes. These lymphocytes are toxic and kill enterocytes. The gliadin also upregulates the stress molecule MICA on the enterocytes and NKG2 receptors on intraepithelial lymphocytes. This leads to cytotoxic killing again of the enterocytes, and it causes the loss of villi, which most of us know that is the histologically the most important sign in celiac disease. All this leads to malabsorption and weight loss. And these activated lymphocytes stimulate the B cells or the plasma cells to secrete autoantibodies, namely the anti-TTG, anti-endomysial, and the anti-gliadin antibodies. Essentially, we will be using these antibodies for the serological diagnosis of celiac disease. So I'll present one or two cases. So there is a case A, there's a 16-year-old male who presented with the following symptoms: weight loss, anemia, and failure to grow. After examination, the clinician asked for the following tests: TTG IgA antibody and endomysial antibody. And there is both a positive result for TTG as well as endomysial. So the TTG IgA antibody is usually estimated by ELISA test. And here you can see that this patient showed a titer more than 200 positive. The diagnosis is then confirmed by doing the determination of an anti-endomysial antibody by immunofluorescence. So the clinical presentation in pediatric cases is: classical symptoms are irritability, abdominal distension, diarrhea, failure to thrive, and weight loss. Most cases present typically between 6 and 24 months of age with history of introduction of gluten in diet. A few cases may present with dermatitis herpetiformis, which has characteristic pruritic papillovesicular lesions on shoulders, arms, and cheeks. There's another case here, a 35-year-old male who presented to gastroenterology clinic with abdominal pains like discomfort, bloating, distension, and weight loss of 7 to 8 kgs in the preceding 4 months. So upon clinical examination, he was again advised TTG and endomysial antibody, and both TTG as well as endomysial antibody were positive. Yeah. So the clinical presentation in adults, the classical symptoms are of anemia, iron deficiency, diarrhea, bloating, fatigue, and weight loss. And these cases mostly present between 30 to 60 years of age. So there's an algorithm which should be used for the diagnosis of celiac disease. This is from Mayo Clinic, so you all can access it later if you need, when you are doing the actual testing in your lab. So it starts with testing for selective IgA deficiency, immunoglobulin A, after which it follows the track of TTG, which I've already discussed, the tissue transglutaminase antibodies, followed by the gliadin antibodies and the endomysial antibodies. I will not go through this whole chart, but after this, the important thing is that you have to proceed to a biopsy, and the biopsy will be a positive biopsy leads to the diagnosis of celiac disease. If, however, there is an inconsistency between the biopsy report and the serology, then the patient has to be tested for the HLA-DQ2 and DQ8. So like I said, diagnosis is based on clinical symptoms and is confirmed with a small bowel biopsy and positive serology. The TTG antibody has a 92 to 100% sensitivity and 91 to 100% specificity. Endomysial antibodies are in adults, again, 85 to 89% sensitivity and almost 100% specificity. Again, the gliadin antibodies are also almost 100% specificity. So mostly the serology, if it is positive, it will indicate that there is a celiac disease. The deamidated gliadin antibodies will also be useful in monitoring the course of therapy and for control of gluten-free diet or gluten loading tests in these patients. They are also important in dermatitis herpetiformis and gluten ataxia. Gliadin antibodies have also been shown to have a role in other autoimmune diseases such as rheumatoid arthritis and also in the non-celiac gluten sensitivity. As this is an autoimmune disorder, it is but expected that there will be more autoimmune disorders which are associated with celiac disease. So you have a type 1 diabetes association, autoimmune liver disease association, autoimmune thyroid disease association, and there is also an association with Turner syndrome, Williams syndrome, and Down syndrome. Coming to allergy, like we saw in the earlier Venn diagram, the largest group of these will be the celiac disease and non-celiac gluten sensitivity. And the third group of patients will be the patients who have an allergy towards either wheat or towards gluten. So allergy is a hypersensitivity reaction initiated by proven or strongly suspected immunological mechanisms. The triggers are substances that subject has been previously exposed and sensitized. So they could be either food, or they could be inhalants, or they could be even contact through the skin or the contact. Allergy can be either IgE mediated or non-IgE mediated. Now, how will you determine or go about approaching an allergy patient? So if a patient is complaining of what he or she thinks is allergy to wheat or wheat containing foods, then please start with a very detailed history. Do take a history in every allergy patient. Also ask them whether they have kept a food symptom diary. So mostly the patients do that. They can tell you that on this day I had a pizza and I had these symptoms. On this day I ate, suppose I seem to have symptoms when I drink milk, or then when I handle a dog, something like this. So food specific, then what you have to do is you have to determine or estimate the food specific IgE. A skin prick test is still considered a gold standard test, and that can also be used for diagnosis of food allergy. Then after this, an oral food challenge can be given using the food which is in question. This, of course, is not done in a laboratory. It is done in a hospital setup. And also an avoidance to these suspected food, and then if there is a better alleviation of symptoms, even that leads to a diagnosis by exclusion. So this is a history form that we use, where we ask the patient the complaints, then the exact symptoms, then any medications if they are taking, the exposure to pollen or to cats and dogs, dust mite, etc. Like with food especially, I already mentioned that we take detailed, we ask them to maintain a detailed food symptom diary and then look at it and then try to determine to which food item they are allergic. Now this particular talk today is about wheat, so we will stick to only wheat and gluten allergy. So here we have we had a case where there was a 6-month-old female, and the moment the milk, she was introduced to cow's milk and wheat, she started showing allergic symptoms. And this is typical. In childhood, the moment you introduce a new food item, the child can show allergic symptoms. This is another case which is interesting. This child came to us when the child was 6 years old, but the child was born in Australia, and the child had been diagnosed at 6 months itself with milk and gluten allergy. So just like the case 1 which I showed you, where that particular patient had come to our lab when the child was 6 months, here the child was already diagnosed in Australia at the age of 6 months, and immediately after that all her milk as well as gluten containing foods was removed from her diet. And when she came here at 6 years of age, she also repeated the test. Now she's living in India, so she repeated the test with us, and if you can see both the wheat IgE as well as the gluten IgE have come, are now negative in her. There is both approaches can be taken. There are clinicians or patients who ask for being tested for wheat allergy only, and there are some who will be tested for both wheat as well as gluten allergy. So here you have a 30-year-old male patient positive for wheat allergen, and a 18-year-old patient here who has tested for gluten IgE positive. This is the data. These are the tests which we have done over the last, from 2018. So if you can see, out of the 53 patients we tested for gluten, about 9 are positive, and about 19 patients tested for wheat allergy, about 4 are positive. More patients going for comprehensive food panels. So we have about 400 people who have gone in for an comprehensive food panel testing. And in these, if you see, about 145 show allergy to wheat, which is almost about 30%. And gluten, again, if you see, in 366 people who were tested, almost 105 are positive. That is, again, 30%. So 30% of the general population without symptoms may show or are showing an allergy to either wheat and or gluten. Coming to non-celiac gluten sensitivity, it is a condition which is characterized by intestinal and extra-intestinal symptoms triggered by the ingestion of gluten-containing food. It is an ill-defined entity, and there's a debate still going on the pathophysiology of this condition. There's an absence of a reliable biomarker, like how you have the serology or antibodies in celiac disease, or you have an IgE test for allergy. In non-celiac gluten sensitivity, there is no reliable biomarker. So what we have to do is we have to think of, we have to first exclude the celiac disease and wheat allergy. In general, the symptoms appear with ingestion of gluten and disappear or better with gluten avoidance, and reintroduction of gluten immediately determines the symptom reappearance. What are the symptoms which you see in NCGS? There can be bloating, pain, diarrhea, nausea, vomiting, stomatitis, and alternating bowel habits, or altered bowel habits rather, overlap with irritable bowel syndrome, functional dyspepsia, and hence there's a huge challenge in trying to classify these patients, many patients, into either gluten sensitivity or irritable bowel syndrome or functional dyspepsia. We will talk about it more later. However, it has also been seen, or the patients definitely say that irritable bowel syndrome also, gluten worsens their symptoms. So there's definitely an overlap between NCGS and IBS. Here are the symptoms which are common to NCGS and wheat allergy: abdominal pain, constipation, diarrhea, nausea, vomiting, headache. Remember, in non-celiac gluten sensitivity, you can have weight loss, musculoskeletal pain, paresthesias, and neuropsychiatric conditions, which you will not see in wheat allergy. In wheat allergy, you will see anaphylaxis, eczema, edema, pruritus, rhinitis, asthma, which you will not see in non-celiac gluten sensitivity. To some extent, when a patient comes to you, from the symptoms itself, you will be able to roughly classify whether the patient falls into the celiac disease group, or the NCGS group, or the wheat allergy group, and then you can go ahead with the laboratory tests accordingly. So, like I said, in these suspected patients, first you test for the celiac disease, IgA and anti-TTG. If the patient has celiac disease, that is one group. If not, then, like I said, you test for wheat allergy with either wheat allergy with IgE testing or skin prick testing, and then classify the patient as wheat allergy. If both of these are not the case, then you have to do an anti-gliadin antibody In addition, put the patient on a gluten-free diet. After a period of time, the patients are given a gluten challenge. And if the symptoms reappear, it will mean that they do suffer from non-celiac gluten sensitivity. So diagnosis, as I said, is elusive. The gold standard for diagnosis of this is a double-blinded placebo-controlled gluten challenge, which is again not done by a laboratory. So it is done by the gastroenterologists or clinicians. In the laboratory, like I mentioned earlier, you can do a gliadin, anti-gliadin IgG antibody. So although there are no specific serological markers for NCGS, it is now being increasingly seen that about 50 to 60% of the patients are positive for IgA or IgG anti-gliadin antibodies. The finding of anti-gliadin antibodies in symptomatic individuals who do not have CD is suggestive, but not diagnostic of NCGS. Conversely, the absence of anti-gliadin antibodies does not rule out NCGS. So here again, you can see the Venn diagram. Now we have put in the tests which we have done. So in celiac disease, you will have a biopsy and anti-TTG positive. In wheat allergy, the anti-TTG will be negative, the IgE will be positive. And in the NCGS, the anti-TTG will be negative. You can have anti-gliadin antibodies positive. Also here, I have now introduced a new term, FODMAPs or carbohydrate intolerance. So I will talk about this a little later. This is a chart which gives you a table which gives you the differences between celiac disease, NCGS, and wheat allergy. So by definition, celiac disease is an autoimmune disorder due to intolerance to gluten proteins. NCGS is a disorder due to gluten proteins, FODMAPs in food, ATIs in wheat. It is different from CD and wheat allergy. And wheat allergy is an allergic reaction to wheat-containing foods through food ingestion, contact, inhalation, or flour dust. A few pointers towards diagnosis are, as you all know, allergy will usually the symptoms occur immediately. It is an IgE-mediated immune response. And it is not dose dependent. So even a very small doses of food can cause anaphylactic reactions in susceptible individuals. In celiac disease, like I said, the reaction time is slow, usually 30 minutes to 24 hours. And here the serology and the biopsy help us in diagnosis. So here the diagnosis is not really a challenge. So where does the diagnostic challenge come? Like I said, in the NCGS group, which is where you have to do the anti-gliadin antibodies, a lot of history taking, counseling, giving a gluten-free diet. So all sorts of trials and errors are happening in the diagnosis of NCGS. So like I said, I was going to discuss FODMAPs. So FODMAP is fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So these are poorly absorbed carbohydrates, and of which a subtype is fructans. So fructans are non-digestible carbohydrates with various nutritional properties, including effects on microbial metabolism, mineral absorption, and satiety. They are present in a range of plant foods, with wheat being an important source. Also, wheat contains 4% ATI, which are known to be the major allergens in baker's asthma. So understand that when you have ingested wheat, okay, and there is digestion of wheat, all the wheat or the gluten cannot be completely digested by the body, and these are digested and absorbed by the body, and these poorly absorbed carbohydrates can lead to different manifestations or symptoms in patients. Now, what is food intolerance? So again, there are many people around you. I will not even call them patients. There are many people around you in your own family members who continuously complain about abdominal bloating, excess gas, nausea, vomiting, abdominal pain or cramping, and non-bloody diarrhea. Now, both food intolerance and IBS patients run the risk of being classified as an anxiety disorder or hypochondriacs, or it is only stress induced, etc. In fact, this was the case for a long period till now. However, now our understanding about both the NCGS as an entity, the irritable bowel syndrome as an entity, as well as food intolerance as an entity is increasing. And we have also understood the concept of a leaky gut. So when you have an intact intestinal barrier and a normal intestinal permeability and a healthy gut flora, that is the ideal homeostatic condition of your gut. And here there is a good food digestion. On the other hand, if you have a leaky gut, that is a leaky intestinal barrier, which could be due to a variety of reasons, such as alcohol, smoking, NSIDs, stress, anxiety. In that case, if you have an increased intestinal permeability and a non-selective entry of partly digested food, proteins, or toxins into the blood, and a gut dysbiosis. Nowadays, there's a lot of talk going on about the microbiome. I'm sure people are aware of it. So what happens here is that the normal flora or the optimum flora of the gut is disturbed, and that is called as gut dysbiosis. So when you have a leaky gut, and if undigested food, proteins, and toxins are absorbed, it leads to the formation of IgG class of antibodies. So food intolerance is mediated by IgG class of antibodies. The prevalence is believed to be 5 to 20% of general population. However, the true prevalence is remains unknown due to insufficient data as well as testing. So IgG food antibodies can result in a delayed response to food. A delayed response to food may be more challenging to determine, because then it is difficult for the patient to tell you what he had eaten 24 hours earlier or 48 hours earlier, and which is leading to his symptoms. The body of scientific evidence continues to build regarding correlation with clinical symptoms and conditions for IgG testing. Non-allergic food reactions are consistently dose dependent. So here they will tell you if they ingest a large amount of their suspect food item, then they are more likely to have symptoms, or that the symptoms will be more severe. So the difference between an IgE mediated and IgG mediated disorder is that IgE mediated is an allergy, which the incidence is relatively low. It results from infrequent exposures, very predictable short-term symptoms. The offending food is usually obvious. At the cellular level, there is a basophil and a mast cell triggered reactions, histamine and leukotriene release, and the treatment for this is permanent food avoidance and or immunotherapy. Whereas IgG-mediated intolerance, the incidence is relatively high, chronic variable symptoms, offending food frequently not suspected or cannot be pinpointed, immune complex is the trigger, and the treatment here would be to eliminate, then rotate foods. When you eliminate the food, the gut may heal itself and the digestion will improve, after which you can actually again reintroduce the insulting food again and see if the patient tolerates it. Then the patient can start having that in his or her diet again. So if you see this particular chart, just come down here, because otherwise it will be a repetition. So here what you can see is, after the celiac disease group, the wheat allergy group, and the NCGS group have been excluded, you come to a group of patients who may be having problems due to the FODMAPs, due to IgG-mediated intolerance, due to an reaction to many of the food additives that are prevalent today, either food preservatives, the colors, Ajinomotos, etc. So there is this one group which where it is very difficult to diagnose and to treat them. Sorry. Sorry, somehow the slideshow is not moving. There are slideshow thumbnail का बघायला येईल. Okay, yeah. So the food intolerance test is done by a microarray ELISA method, where if you, as you can see, there's a chip on which a large number of food items are on the chip, and the serum is applied to this, and the IgG antibodies can be detected. So this is the report which is available, in which there is a variety of food items, as you can see, and they will be classified as the foods which are normal, I mean the patient has no reaction to them, or the foods where there's a borderline intolerance, and foods which are in red, which have to be definitely avoided by the patient. Now this particular report will act as a guideline or guidance to the patient as to what foods he or she can avoid, and see whether there's an improvement in the symptoms. So food intolerance is a new entity, as we can call it. It is like last 4 or 5 years where there's a focus on both in food intolerance as well as irritable bowel syndrome. At the same time, when we started doing the test and started looking at the reports, what we realized that most of the times the results are revealing what we have always known as an age-old wisdom, or your granny's wisdom. You know, we all remember that we were being told to eat light foods when we are sick, because at that particular time, yes, we may have a leaky gut. It was always said that yes, don't eat foods which are difficult to digest. Then also there's a logic in seasonal foods being eaten in that particular season, because the body temperatures and the type of the temperature of these foods are supposed to be what will I call, compatible with health. Then again, it is always said that certain kinds of food should not be mixed. We are always told to eat slowly, calmly, and chew 52 times, because otherwise the digestion of the food is not good, and these undigested food items are the ones which are going to lead to food intolerance. Then drinking buttermilk to improve the flora or improving the microbiome. So all these things which were vague and could be considered as myths, maybe today the food intolerance testing has started on in large numbers. These tests are being done, and probably our collective knowledge about food intolerance will improve and better within a while. So these are there's a Fadiatop, we do our allergy testing on the Fadiatop platform, and we do our food intolerance testing on the Foodprint. The last is irritable bowel syndrome. Again, a very, very ill-defined entity today. And it is what happens with us. We are getting patients who come to us and give all these symptoms. They will talk about abdominal pain, vomiting, nausea, bloating, gas, etc. And then as a lab, we are also put into a fix as to how to approach and which tests. If they've not seen a clinician, here why I'm again and again saying that the lab has to guide sometimes and talk to the patient is because many of these patients are self-diagnosed. They are suffering from these symptoms for a long time, chronic. They're like 3 years, 4 years, last 5 years, I'm having symptoms of bloating, dyspepsia, etc. They have already undergone ultrasound. They have undergone OGD scopies at times. They have seen multiple clinicians, and still they are not being able to come to a diagnosis. So irritable bowel syndrome is a heterogeneous disorder with multiple etiologies, and there's a chronic abdominal discomfort, pain, and variable bowel habits. No organic cause is usually seen. Now here you can see that there is the confusion or the overlap which I was talking about. So this is the World Journal of Gastroenterology, and look at the title of the paper: Food Allergy in Irritable Bowel Syndrome, the Case of Non-Celiac Wheat Sensitivity. So till now I have spent time trying to separate out these three entities to the audience, and here you have a paper which is talking about all three these things in the same breath. So which means that we need a well-defined approach towards these patients. So the right approach will be one, a very, very detailed history taking, because the table which I've shown you earlier. So if just try to note whether the symptoms are immediately after food ingestion or a slower reaction, see whether there is weight loss, see whether they can pinpoint the food, try to see whether the symptoms fit into the NCGS or the celiac or category or the allergy category. Very important to have an empathetic approach, because like I said, most of these irritable bowel syndrome patients are very, very uncomfortable, but they have been classified as anxious patients, stress related, then due to irregular timings of meals and sleep. So they have been kind of ignored. So instead, we have to have a good history taking and an empathetic approach towards them, and then do a stepwise testing. Of course, we have to rule out anatomical and structural conditions. We, in the sense, the clinicians will have usually rule these out with ultrasound or other radiological investigations or scopies. Now, like I said, from the lab, the first would be to exclude celiac disease by serology and biopsy, then go towards wheat or gluten allergy testing, after which you can do the anti-gliadin antibody testing, which may indicate an NCGS, and then you can offer a food intolerance test to these patients. Then, like I already mentioned earlier, the gluten-free diet trial can be done. A purified gluten challenge can be given to the patient. And last but not the least, there's HLA typing for the subclinical group, CD group. So thank you. And as you can see, on one side, there are these wonderful food items which are laden with gluten and sugar and fats. And today we are all moving towards fat-free, salt-free, caffeine-free, all sorts of food fads, as well as food, I would not even say fads, but also requirements. So suddenly in the last 4 or 5 years, what we are seeing is a large interest in food-related problems, disorders, and the role of laboratory in these. Thank you again.